representatives of Greater Los Angeles Valley Children's Center, today we will be presenting our recommendations for sustainability and population health management. We will begin with some background information on the organization. We'll move into our business proposal, explain how we will implement it and what we expect to gain, and then we will finish up with our financial projections to restore the hospital to financial viability. Greater Los Angeles Valley Children's Center, which we will refer to as the Children's Center for the remainder of the presentation, is a pediatric hospital located in Riverside County, California. Beginning in 2010, the hospital experienced an unexpected growth in their emergency department, which led to increased expenses, and neglect in the ambulatory care center led to a decrease in outpatient visits. The Children's Center is a 176-bed, standalone children's hospital with an adjacent ambulatory care center. The hospital serves the population that's in Riverside County as well as San Bernardino County, which makes up the Inland Empire. About half of the population are Medicaid patients, and through partnership with pediatric specialists organized through the Independent Physician Association, the hospital provides a variety of services, including emergency services, inpatient acute and critical care, outpatient, surgical, and ancillary support services. The Children's Center, marked by the green pen, sits on the border of Riverside County, outlined in purple. As you can see, the hospital service area extends beyond Riverside County and moves into San Bernardino County, and the competitors surrounding the hospital give us opportunity to penetrate that market and position the hospital for greater success in the future. The population that the Children's Center serves is one of the most rapidly growing communities in California. The poverty levels in this area are continuing to increase as well. About a quarter of the population are children, and 3/4 of those children are not active most days of the week. Some other areas of concern with these children are the rate of asthma and the low vaccination rates. So what we are planning to do is to restore the Children's Center's financial viability, restore their operational performance, and position the Children's Center for market success. And we would do this by managing costs, increasing our outpatient utilization, and creating a continuum of care. We were presented with several options in the case, and the best option was for us to affiliate with Riverside Medical Clinic and Riverside County Family Centers, and then leverage our partnership with our pediatric specialists that are organized through an Independent Physician Association. Through that partnership, we will manage care to move towards an ACO model in the future. The key stakeholders in this venture are the Children's Center, Riverside Medical Clinic, Riverside County Family Centers, our pediatric specialists, our patients, local schools, because there is an opportunity to place vaccination clinics in those schools, and then also our state and public agencies, because there is an opportunity to reduce healthcare costs. Riverside County Family Centers is a federally qualified healthcare organization with 10 locations throughout the Inland Empire. They are skilled at providing primary care, which includes screenings and vaccinations, and they see over 150,000 visits annually. We will look to their partnership to provide primary care to our patients that we cannot otherwise provide. We believe that we can provide them with easy access to our specialists, which they wouldn't otherwise have. Additionally, the community outreach programs that they have, we can use the affiliation to venture those outreach programs into the local schools and provide vaccinations for children and other support services as needed. Riverside Medical Clinic is a healthcare provider with 5 service locations in our service area. They are a provider of primary care, limited specialty care, health education, and most importantly, urgent care. Because we've had an increased volume in our emergency department, we see the opportunity to educate our patients that present to the emergency department with non-emergent symptoms and move them out of the emergency center into a more appropriate, cost-efficient setting, such as the urgent care center. We also believe that we can provide their specialists with additional places to practice, and we can extend the services that they provide because they only have a limited amount of services. So with the three-party affiliation in place, our new network within our service area will look like this. And in order to make this happen, we would have to leverage our partnership with our pediatric specialists. And there are opportunities to place some of these specialists in some of the select clinics, such as Hammett and Beaumont. Strategically, we see this as the best time to leverage this partnership with our physicians because of the DRG model implementation that started in July of 2013. And then additionally, at the beginning of 2014, these physicians will experience a budget cut. By mid-year 2014, we expect to have our contracts outlined with our affiliates. And by 2016, we expect to realize our budgetary goals, keeping in mind that we want to move towards strengthening our relationships within the community. So now that we've explained to you what we're planning to do, Nikita will explain to you how we will get our providers on board.
Thank you, Sarah. All right, so our marketing approach really focuses on two different groups, the providers and the community. So let's look at the provider side first. The goal of the marketing approach is to really maximize buy-in from the providers. So looking at why they would want to join in an affiliation like this. So looking at the primary care providers we would be affiliating with, we would propose to allow them access to increased specialty care as well as access to medical records for when their patients access specialty care. We also plan on offering them discounted prices for their patients when they are referred to our facility, as well as access to advanced technology in our hospital setting. We did consider that certain primary care providers that are currently employed by Riverside Medical Clinic are affiliated with general acute care hospitals in the area. These hospitals they provide a very little amount of pediatric care, so we would extend to them treat and release agreements as well as discounted pricing for pediatric subspecialties that they do not currently offer. Next, looking at the pediatric specialists. This group includes two different groups, actually. The first group is the physicians that are currently affiliated with us through the pediatric IPA, and the second group are the group of 18 physicians that are currently employed by Riverside Medical Clinic. So looking at the IPA physicians, we plan on offering them increased access to primary care as well as increased referrals from this new primary care network. We also plan on placing some of these specialists in an FQHC setting on a scheduled basis. This offers them an opportunity for increased income as well as a potential for loan forgiveness by providing service in an FQHC setting. Now turning to the Riverside Medical Clinic specialists, we will offer them hospital privileges, and this is a way to better manage their patients' care in a hospital setting as opposed to a medical clinic as they are currently operating. So with this new network of providers, including Riverside Medical Clinic's urgent care, both of our partners' primary care, and our offering of specialty, emergency, and critical care, we really plan on fostering a patient-centered approach that will increase communication between providers and increase access to medical records at all levels of care at all of the facilities in the network. Now moving to the marketing approach to the community. This can really leverage our easily accessible 17 locations in our network, providing all services from primary care to tertiary care as well as preventative care at certain locations at an affordable, low cost to the patient. Being an organization that's really rooted in the community, we also wanted to look at increasing our presence and our education resources in the 25 school districts in the area, as well as at community events. So tying this all together, we really plan on managing the health of the population we're serving through the variety of care that we're offering, the locations, the coordination of care through the increased communication in the EMR system, as well as expanding and integrating the health education resources as part of our new network into the community. So in order to really monitor the success of this proposal, we'll of course be looking at health outcomes as well as patient satisfaction. But one thing we wanted to emphasize was looking at associate and physician engagement. This is to really assess how the physicians and the associates being any staff affiliated with the network, how they are aligned with each other, as well as how they are aligned with the network and the future vision of the network. We'll also be looking at growth in financial status. So being a children's hospital, we expect our inpatient and outpatient referrals to increase with our new primary care network, as well as with the population growth in the area, we expect our emergency visits to increase as well. So this proposal really puts us in a place to be prepared for the changes that are coming with healthcare reform. So the network itself can look forward to some positive changes, including increased access to coverage for all children, as well as incentives for improving outcomes, which is something that this proposal really sets up nicely for these providers. This proposal also will prepare the network for some of the negative changes that will be happening, including Medi-Cal budget cuts. So this will include the transition that's already in place, moving from cost-based reimbursement to the DRG model, as well as the physician cuts in reimbursement for the Medi-Cal program, as well as the potential for disproportionate share hospital cuts coming in the future. So to further explore the financial analysis, I will hand it over to Omar.
Thank you, Nikita. In looking at our projections, we'll begin by taking a look at our volumes, beginning with our inpatient volumes. Now, despite the decline in volume between the years 2011 and 2012, based on the implementation of our model as well as the overall rapidly increasing population, we are projecting higher volumes in subsequent years following 2013. That same logic also applies in outpatient volumes following 2014. As you can see here, outpatient visits are being projected at a rate of 16% growth between the years 2013 and 2016, with adjusted patient days at roughly 26%. Additionally, adjusted admissions will be growing at a rate of 6% over that same time frame. In looking at additional lines of service, due to the rapidly increasing nature of our ED, we do believe that that growth will continue, notably with our ED admissions as well as inpatient and outpatient surgical cases, among other diagnostic services. As you can see here, due to that increase in volume, we project these at a rate of 23% between the years of 2013 and 2016. In exploring our pro forma, I'd like to begin with our inpatient revenue sources. As you can see here, despite the loss in volume between the years 2011 and 2012, we did receive an increase in our revenue stream between those same years. We do project that with the additional volume, we will see additional revenues in those subsequent years. The same applies again with the outpatient service line, beginning with 2014. In exploring our uncompensated care, due to the implementation of the Affordable Care Act, we do believe that despite the deepening loss between the years 2011 and 2012 into 2013, as the Affordable Care Act is implemented, we do expect to see slower losses in uncompensated care. Now, regarding contractual deductions, if I may bring your attention to the DRG impact chart listed below, due to the declining reimbursement due to the DRG model, which began on July 1st, we project losses based on 2013 volumes at a 5% rate in 2013, 10% in 2014, 15% in 2015, and moving forward. If I may draw your attention, by 2016, we project a net income of $16 million tied to a gross operating margin of 6%, which places us right in line with other profitable children's hospitals. Additionally, in looking at total other operating revenue, because the case did not define what that source of revenue was, we did not feel comfortable trending that out despite the overall increase between 2011 and 2012. In looking at our projected net income, we do believe that this growth is also tied to the shift in population out of inpatient and emergency department into the more profitable outpatient setting. Additionally, this growth, while it is significant in years 2014 and forward, we do believe that this will slow due to cap constraints as defined by our facilities capacity. In looking at our net operating revenue, we believe we took a conservative approach in trending out our revenues and expenses. Should we have taken a more aggressive approach, we do believe we would see higher levels of net income. As you can see here, our projection is the blue line towards the right. More aggressive approaches to those revenue and expense growths are illustrated in red and green. In looking at the impact of the Affordable Care Act, we do believe that despite our deepening losses in 2011 into 2012, in 2013, that we will see much lower expenses due to uncompensated care as the Affordable Care Act spreads and covers more lives. In looking at our overall 3 objectives, we set out to restore financial viability, restore operational performance, as well as position the Children's Center for overall market success. We will do these primarily begin with restoring financial viability. This begins with controlling our expenses by freezing new hires, optimizing our relationships with our providers through our renegotiated contracts, as well as the formation of group purchase agreements to help control our skyrocketing expenses. In restoring operational performance, we intend to do this through enhancing our relationships with our affiliates, as well as facilitating health plan enrollment as guided by the Affordable Care Act. Finally, in positioning the Children's Center for overall success, we intend to do this through creating that continuum of care that our area desperately needs with our affiliate partnerships. This concludes our presentation. This time we'll take questions.
Thank you. Y'all did a great job. Great job. So we're looking at these 2 partnerships combining with the Children's Center. As far as duplication of services and staff, and I know that the whole goal part of this is that you're not going to increase your overall operating expenses, basically. So how are you going to cut staff, or are you going to cut staff, or are there some duplication of services between the 3 that you can minimize? And that you thought about that?
Sure. As far as services, we've noticed that the Children's Center doesn't provide primary care, and the 2 affiliates are strong providers in those areas, one of them being the FQHC, and we think that a large part of our Medicaid population will be seen in that setting, and then our other commercial payers can be seen in the Riverside Medical Clinic, should they choose to go there. As far as staffing, we made a conscious effort not to cut staff because we weren't sure of the actual staffing that the Children's Center had. So we wanted to freeze new hires and make sure that we can control those costs going forward.
Okay.
Excuse me. As a follow-up to that, you mentioned offering discounted rates, lowering costs, accommodating budget cuts. The main drivers of your efficiencies, your operational efficiencies, could you just highlight? I know you mentioned freezing new hires, optimizing contracts, creating group purchase. Could you tell me, are those the main drivers, and what scale are you expecting to save from each of those, just grossly speaking?
Sure, so a couple of things with that. As far as other factors that we're going to do to reduce our expenses, as was outlined in the case, there was a disproportionate staffing that we believe accounted to the high costs in the ED. So in exploring that shift of population out of those less profitable settings into the more profitable ambulatory setting, we believe that'll be one source of revenue that'll help outweigh those rapidly growing expenses. Additionally, through that group purchase agreement, as was also outlined in the case, we saw rapidly increasing expenses that did not necessarily correlate with the higher volume of visits. So in entering this group purchase agreement with our now 17 sites, we believe that'll help slow those as well. Now, to your point about how they stagger in terms of each individual thing, we did not necessarily trend that out by each factor.
Thank you.
Can you explain to me, with the 16% projection and admissions that you're projecting, how did you come up with that growth rate? And then how does that break down with the affiliations with Riverside Medical Clinic and the Riverside County Family Centers?
Sure. So there's a couple of things with that one as well. First and foremost, Riverside County as well as San Bernardino counties are going through a very, very rapid population increase. We tied that population increase directly to our ED growth, which was growing despite losses in outpatient and inpatient volumes. Now, based on our implementation of the model, we do expect higher levels of outpatient referrals inbound in addition to that volume increase.
But how did you come or derive that 16% growth in admissions? Like, what balance, or where are they coming from? Are you expanding your service area? I'm not clear on where that 16% is really coming from.
So our service line is increasing, or service area rather, is increasing based on the new locations that we have. Additionally, because of the adequate managing of care through our primary care referrals, we do expect higher levels of inbound referrals. Now, coupled with that population growth, we expect that to help stimulate that 16% growth.
Okay, and just one follow-on question with that. So the FQHC, do you know what percent of Medicaid they see? Because traditionally, I know FQHC see mainly Medicaid patients. So I'm concerned about our 53% of commercial patients and how we're going to continue to appeal to them and ensure that we continue to get their business.
Sure. In looking at our partnerships, we do believe that our FQHCs are predominantly going to be Medi-Cal patients. Looking at our current payer mix before any changes, we're at about 48% of our payer mix breaks down to Medi-Cal. So counting that influx from the FQHCs, we also believe that through our clinics, which have a decent amount of commercial payers, that we'll see that influx as well from their side.
Thank you.
I'd like to follow up on the question around the physician alignment piece, because presumably you're bringing together groups of people who were competitors before, right? Riverside Medical Clinic and then the IPA of Greater Los Angeles Valley. What are your strategies around creating a physician alignment, and how are you going to have them change their behaviors of being incented only by their own practice?
So one of the things, as mentioned in our metrics section, we had a plan to, okay, let me back up. We have pediatric specialists as part of the IPA, and then primary care physicians as part of our new affiliates. So these are groups that didn't necessarily communicate with each other prior, and that's something we want to facilitate through this affiliation. So they wouldn't be competing for the same service lines because they are providing different services, but with our affiliation, we would want them to begin to communicate more with each other. So looking at follow-up visits after seeing, so with a primary care patient being sent to specialty care, we would look at whether the follow-up visit with the primary care physician happened, whether they were communicating with each other about what types of care were provided to the patient, whether the physicians are happy with the care that their patients are receiving, and being able to really track and get their patients back into their own level of care when they need to.
I was thinking more of the competition between the specialists who care for patients at Greater LA and the specialists.
Riverside.
Right,
Okay,
right.
so but that was something we considered. Right now, we did see that the hospital does provide more subspecialty care that the clinics don't necessarily provide. So by allowing that them more to cooperate and be able to use the facilities and use each other as resources, facilitating that cooperative nature as opposed to the competitive nature is something that we were looking to encourage.
Okay, thank you.
Mm-hmm.
Let me follow up on that. What kind of increased payments do you see the pediatric specialists getting, and will there be any issue around how you characterize the increased payments for the increased referrals?
Well, so we didn't necessarily look at increased payments because we realized that the budgetary cuts will hinder that.
I'm referring
forward.
to slide 16 where you have increased payment under pediatric specialty providers.
So that was when we would be sending them to the FQHCs, and that would be an opportunity by servicing patients in a different setting that we would do a form of joint shared payment, increased payment to the physician between us and the FQHC, since they would be providing care at that setting. So not necessarily increasing payment in our hospital when they're servicing patients in our hospital, but when they are in the FQHC setting.
So you're saying, so it's just that they're providing some more services?
Right,
Correct.
right.
And with our increased volume, we're expecting for those physicians to be able to see more patients, and that will lead to more payment.
But the FQHC payments are really the Medi-Cal payments. And do you know what their mix is right now in terms of Medi-Cal to commercial, and why would they want to have more Medi-Cal patients?
Well, the FQHCs are skilled in providing care to Medicaid patients or Medi-Cal patients. So we're expecting that they can accommodate for that increased volume in their setting.
Now, I'm asking you, why would the physicians want additional Medi-Cal patients? Because those are the low-pay patients.
I see.
So there are a couple incentives with physicians providing care in the FQHC setting. As Nikita alluded to earlier, in being a physician who does provide care at an FQHC, you are eligible for certain programs, including loan forgiveness, among other benefits. Additionally, based on the demographic location of these physicians, they may actually be located closer to these FQHC sites rather than that commute into the Children's Center.
Have you analyzed the risk associated with the strategy that you've proposed?
Not necessarily. The one caveat with this case is that it's entirely tied on various levels of assumptions that we had to make. Many of those assumptions centered around this population growth as well as the overall implementation of our model, bringing in that outpatient referral source into our clinics. That level of risk, it will stand. Apart from that, we have not explored any further risk.
I have one more question. So you talked about EMR coordination being a key component here. It looks like one group is up on Epic. Are all groups up on Epic? And is everybody up on Epic? And if not, what would you centralize to? And how would you cover those expenses?
So one assumption that we did make was that they were all on the same system.
Okay.
However, if they weren't, we did discuss providing access to view records at various locations in the first phase, and then as integration continued and the process matured, we would consider investing in a synchronized EMR.